Hi everyone, today we'll be discussing an approach to bradycardia and AV block. This video is meant for intermediate and advanced users. This is actually the first video of a three-part series. In the first part, in this particular video, we'll talk about the normal conduction system of the heart and some physiologic forms of AV block. In the second video, we'll talk about pathologic AV block mechanisms and how to risk stratify patients with AV block, which patients don't need any treatment and which patients need emergency treatment and which patients can wait. And in the third part, we'll discuss mechanisms of sinus node dysfunction and management. Sorting out bradycardia problems, and any arrhythmia problems for that matter, is like a game of chess. You first have to know the rules. You have to know what each piece does on the chessboard before you can learn strategy. And similar with EP, you have to learn certain EP principles before you can apply them to tracings. And that way you can formulate your approach. For example, what is wanky back? What does it really mean? So bear with me for the first part of the talk. There is some physiology, but I promise it's straightforward and we'll use every bit of it. And hopefully by the end of these videos, you'll be more confident at approaching bradycardias and AV blocks on tracings. So let's very quickly go through the basics. This is the SA node. It's a crescent-shaped structure at the base of the SVC at the crista terminalis. And the job of the SA node is to fire at a fixed schedule to pace the atria. It has atrial cells with the fastest automaticity. This here is the AV node. And the job of the AV node is to block signals from rapidly conducting down to the ventricles. If the patient's atrial rate suddenly accelerates, for example, if there's atrial fibrillation, where the atrial rate is 600 beats a minute, or atrial flutter, where the atrial rate is 300 beats a minute, the AV node blocks some of these signals from traveling down to the ventricles and activating the ventricles too quickly, because the ventricles cannot sustain such high rates, and it would result in ventricular fibrillation. So I repeat an important point: the job of the AV node is to decrement and block signals. Everything below the AV node here is what we call the Infra-His conduction system, or the His-Purkinje system. And it consists of the bundle of His, the right bundle, which quickly travels to the right ventricle, and the left bundle, which activates the septum in a left-to-right fashion. And then the left bundle divides into the left anterior fascicle, the left posterior fascicle, and the fascicles insert at the base of the papillary muscles. And there's also the Purkinje fibers, which further quickly spread the electrical activation throughout the myocardial cells. Okay, so the job of an infrahisian conduction system is to conduct, never to block, but to conduct signals quickly and synchronously to the ventricles. So a narrow QRS is formed when the ventricles are quickly and simultaneously activated. And to do this, we need both bundles to function well and to conduct quickly and synchronously. And you also need fully functioning Purkinje and myocardial cells. Any conduction slowing or dyssynchrony causes a wide QRS. The main clinically relevant question is, does this patient need a pacemaker? So let's take a few moments to go through that. And there are two main groups of people where a pacemaker is indicated. The first one is symptomatic bradycardia. If a patient's having symptoms that are attributable to bradycardia, then a pacemaker is generally reasonable to improve their symptoms, okay? And in this case, the benefit of the pacemaker, the symptomatic improvement, has to outweigh the risk, okay? And this is regardless of the mechanism of the bradycardia. So this could be Mobitz 1, chronotropic incompetence, sinus node dysfunction, and others. The second group of patients where a pacemaker is indicated are those with conduction system disease and poor prognosis. Now, in this group of patients, it's not as obvious as the first group of patients because these patients may not have any symptoms. And it's up to the clinician to recognize that this is a conduction system problem with poor prognosis that we need to put in an urgent pacemaker before a bad outcome happens, okay? And by poor prognosis, I mean syncope, asystole, and cardiac arrest. And conduction system problems that have a poor prognosis are generally those with a complete heart block and a concerning infra-his conduction block, okay? And we're gonna spend a lot of time on this because this is the part that's very important that clinicians have to recognize this on the ECG. And the concerning infra-hisian conduction block examples are Mobitz 2 pattern and alternating bundle branch blocks. And in general, if the bradycardia is reversible or the cause of the bradycardia is correctable, it's best to hold off on the pacemaker, correct the underlying cause, and reevaluate the pacemaker indication after. So let's apply what we learned to this tracing. So if you'd like to pause this video now and pretend that you're reading this Holter monitor, and the question is, should you be worried? Does this patient need a pacemaker? So the first thing I do when I see a pause like this, I like to caliper out the sinus node activity and the ventricular activity to see what exactly is happening. So this is the sinus interval, the A to A interval. Then I caliper this out. This is where calipers become quite handy. And I move it over 1, and I note that the sinus P wave is missing. Okay, and the question is, why is the sinus P wave missing? I look at this T wave as a normal templated T wave, and I compare it to this T wave of the last beat. And I note that there is very high frequency signal right there, right in the T wave. So there's a P wave in there, and it's a premature P wave, it's a PAC. And this PAC does not result in the QRS, so it got blocked in the AV node. And this represents classic non-conducted PACs. This is a very common phenomenon that you see on a large portion of the Holter studies that we review. Okay, and this represents normal physiologic activity of the AV node, because you give it a long A to A interval, and then you give it a very short A to A interval. And the AV node is very good at blocking early, very fast beats. And so it blocked this PAC, which is normal physiologic function of the AV node. Okay, so this is not concerning. In the previous example, we had a non-conducted PAC that's blocked in the AV node. This is an example of AV nodal activity. Whenever you hit the AV node with a long short sequence of a PAC, it tends to block. Sometimes the AV node blocks sinus beats, and we don't have PACs to look at. And we need to look for different signatures of AV nodal activity. And a very common signature of AV nodal activity is Wenckebach or Mobitz 1. Wenckebach is characterized by progressive PR prolongation with each cycle in the Wenckebach sequence until the P wave is blocked in the AV node and non-conducted. And then the return beat, the PR interval resets to the original. So it's important to note that Wenckebach or Mobitz 1 is not quite a diagnosis. It's more of a signature or a pattern that you see on an ECG or a Holter monitor tracing. And it's suggestive of that the block is at the level of the AV node and not below the level of the His in the His-Purkinje system, which is a lot more dangerous. An interesting phenomenon, which is a common question used by heart rhythm cardiologists to torment trainees, is when you measure the first RR interval and compare it to the subsequent RR interval in the sequence, you note that it's shorter. And with each cycle in the sequence, as the PR interval prolongs, the RR interval shortens. It's an interesting mind-bending puzzle, which has very little clinical relevance, honestly. But if you really sit down and think it through, you'll find that the RR interval depends not on the PR interval magnitude, but rather on the rate of change in the PR interval. So in the first cycle of Wenckebach, the PR interval grows the most and leads to the largest RR interval. And in the subsequent subsequent cycles, the PR interval grows by a smaller amount and the RR interval shortens. If you're interested, you can download a set of calipers and work it out yourself. But that's the main gist of it. So we won't spend a whole lot of time on that because, as I said, doesn't have a whole lot of clinical relevance. At this point, I wanted to mention the importance of the autonomic nervous system. The sympathetic system of nervous system affects the entire heart and increases the automaticity, the rate of firing of the SA node, and it also increases AV node conduction and reduces AV block. So when you're on a treadmill, the AV node can conduct as fast as 170 to 200 beats a minute because the sympathetic system makes it slick. And when you're sleeping or post-exercise, the parasympathetic system takes over and becomes dominant, and it affects the sinus node by slowing the sinus rate, and it affects the AV node by slowing its conduction and increasing its refractoriness. which manifests as PR prolongation and AV block. In Wenckebach, I want you to think of AV block as a continuum. So for example, this is the strip that we saw earlier, and we often communicate the severity of Wenckebach by comparing the ratio of the conducted to non-conducted beats. So in this particular case, there's 4 P waves and 3 QRSs. So one of the P waves is blocked. So this is a 4-to-3 conduction. In the second example, we have 3-to-2 conduction. This is when Wenckebach becomes slightly more intense and you have every third beat instead of every fourth beat blocked in the AV node. And in the third case here, this is 2-to-1 Wenckebach. So there's 2-to-1 conduction down the AV node. This is a very common tracing that we see on Holter monitors, and especially for patients who have vasovagal syncope. Whenever a patient gets vasovagal, they have substantial parasympathetic activity. Their AV node starts blocking in a signature AV node fashion. So this is PR prolongation Wenckebach like we described, and it gets progressively more severe like you see here. And if you keep monitoring them, their AV block gets more and more intense, and at some point they'll even have a systole and they may pass out. If we keep monitoring the patient, their AV node gets increasingly stimulated by the parasympathetic nervous system. The AV block gets even more severe, and they can even develop a systole for a period of time where they lose cerebral perfusion and pass out. And if you look at these tracings, you're looking for classic signatures that tell you what is the level of the block. If it's the AV node, the prognosis is good. It's just physiologic parasympathetics causing this, and it's not malignant Infra-Hisian disease, which generally has a high risk of cardiac arrest and sudden death. The other observation that is very reassuring is look at the sinus rate. As the AV block gets progressively more severe, and during this episode, you see the sinus rate starts to slow. Compare this P2P interval and this P2P interval, and you see that the sinus rate is slowing. And the question is, why is there AV block and sinus slowing at the same time? These are completely separate cardiac structures. And why would both cardiac structures be affected that are completely unrelated? And the answer is it's the parasympathetics. Seeing sinus slowing at the time of AV block strongly suggests that there's parasympathetics at play here, because during malignant AV block, the sinus node wants to ramp up because the sympathetics are being activated because the person's cardiac output substantially drops. So looking at the sinus rate and comparing it to a few seconds before the AV block episode is extremely helpful. And if you see sinus slowing, you're thinking parasympathetic nervous system. The third observation that's also very reassuring on this tracing is look at the time. This is happening in the middle of the night when this patient is likely sleeping. We very commonly in the heart rhythm world get referrals where this patient gets a Holter for a separate reason and they find nocturnal AV block. And when you talk to the patient, they have no symptoms whatsoever, and they're wondering why you're even calling me about this. And certainly the nocturnal AV block is not as worrisome if the patient is asymptomatic, because parasympathetics are most active at night when the patient is sleeping. So isolated nocturnal AV block is generally quite reassuring that this is likely AV nodal. And certainly you would look for other features to help support that conclusion. We very commonly see referrals for this kind of thing in the intensive care unit. When the patient is intubated and is getting airway suction, somehow this airway manipulation produces significant parasympathetic surge. And patients develop this progressive Wenckebach and a systole, and sometimes even the sinus node can also arrest because it's getting input from the parasympathetic nervous system, just like the AV node is. And the patient can become sweaty, their blood pressure drops. This is all parasympathetic vasodilation and bradycardia. And sometimes a systole can be extremely long, even up to 30 seconds, and the patient sometimes get CPR for this. And no doubt, it is very distressing to the physicians, to the nursing staff, and the patient, and it's very scary. but you as a trained physician can look at this situation, you see a precipitant, you look at the tracings and everything's consistent with a normally functioning heart. You can be reassured that the long-term prognosis from the conduction system standpoint is good. This patient does not need a pacemaker. And certainly, if this keeps recurring in the ICU, the patient's heart rate can be supported in a number of ways, either pharmacologically or with temporary pacing. So to summarize, look for signatures that the block is at the level of the AV node. And things you look for are PR prolongation, sinus slowing, which suggests autonomic input, and then classical clinical presentation. And I cannot stress this enough. It's important to talk to the patient, ask them what is the precipitant, what is the trigger, and what is the story? Was there prodrome, postdrome? And does this patient have any structural heart disease? For certainly patients who are young, had prior recurrent syncopal spells are the ones that are more likely to have reflex syncope from parasympathetics. And look at the time of day. If it's only nocturnal and the patient is asymptomatic, this is something that's generally not worrisome. So to summarize, we discussed the conduction system anatomy and physiology and applied it to tracings. We also went over the normal function of the AV node and what are some signatures on the tracing that AV node is in play and is causing AV block. We also discussed the autonomic effects on the conduction system and the innervation of the heart, as well as autonomically mediated and reflex syncope. And we saw an example of how classically reflex syncope manifests on a tracing with progressive sinus slowing and AV block and a wanky back pattern. And there are different types of reflex syncope. Some of them include vasovagal, but there are also orthostatic syncope with positional changes. There's situational syncope, classically if someone's in the washroom and they have post-micturition syncope. There's also carotid hypersensitivity, and the classic example is a patient who is shaving, who stimulates the carotid body, which leads to a big parasympathetic reaction, which manifests on the tracing as a classic reflex syncope pattern that we saw today. So this concludes the first part of a three-part series on AV blocks and bradycardia. In this particular video, we went over the normal conduction system and some physiologic forms of AV block. And in subsequent videos, we will go through some pathologic forms of AV block. In particular, we'll discuss Infra-His conduction disease and sinus node dysfunction.